Hello. Welcome to today's video session. Today we'll be covering Rural Health Clinic Overview for 2021. Today's date is January 5th, 2021. My name is Charles James. I'm President and CEO of North American Healthcare Management Services. We're a revenue cycle management company located in St. Louis, Missouri, and we provide services to physician practices, nurse practitioner PA practices, rural health clinics, and FQHCs across the country. Of course, we do a lot of rural health clinic and FQHC program implementation, 340B auditing, cost reporting, provider enrollment, and a host of other consulting services. Today's topics, as I mentioned, are the Rural Health Clinic Basic Overview. So we'll be looking at some basic definitions, rules, and guidance, where we can find the statutes, who are RHC providers, and what are RHC locations. I'm going to talk a little bit about our encounter rates, and then we'll move on to what are rural health clinic services and what are not, how preventive services for Medicare are covered in RHC. Telehealth is an important topic these days, so we'll talk a little bit about pre and post COVID telehealth parameters. We'll touch briefly on value-based payments, and since this is a recorded session, of course, we won't have any questions. So, RHCs were established by Congress in 1977. The purpose of RHCs were to address the inadequate supply of primary care providers in rural America. So, inadequate supply of physicians serving Medicare beneficiaries in underserved rural areas, and to increase utilization of nurse practitioners and physician assistants, rural health clinics were established. So we've been eligible to participate in the Medicare program since March 1, 1978. We're paid an all-inclusive encounter rate per qualified primary care visit and preventive health service. So notice it says per qualified primary and preventive health services. We're going to talk about what are those qualified services and what are not. One of the most important aspects that is by statute cooked in, that means it's cooked into the law, is that we have to be primarily a primary care services clinic. We have to offer primarily primary care. We do that, and we're assessed on whether or not we're primarily primary care by whether or not 51% of our total provider hours are being rendered by primary care providers. So 51% of our total provider hours must be family practice, internal medicine, OB, or PEDS. So the purpose is for a rural health clinic to receive special reimbursement, i.e. cost-based reimbursement, and we want to improve access to underserved areas for these specialties. And to do that, remember, we're increasing access. We have to have at least 50% of our weekly clinic hours staffed by a mid-level practitioner. Now, mid-level practitioners all throughout the guidance, so that's why I continue to use it here. So based on total provider hours is our primary care gauge. And our nurse practitioner PA threshold is 50% of our weekly clinic hours. So if we're open 40 hours per week, we have to have 20 hours of a nurse practitioner PA, which is different than if we have 4 providers. We have total hours on those 4 providers in our clinic are, what would that be, 160 hours per week. We have to have at least 81 of those hours as primary care. So our primary care is based on total provider hours. Our nurse practitioner staffing is based on weekly clinic hours. So they're two very different. So weekly clinic, usually 40 hours per week, unless maybe we're in urgent care. Very different than total provider hours for the 51% primary care. This is a common cause for confusion. We have various 50% or 50 numbers that we work with in rural health, so we have to be sure we're not confusing those. Rural health clinics were established and defined in the Social Security Act, and we're facilities that are engaged primarily in providing services typically furnished in an outpatient clinic. So we can quibble a little bit with that primarily providing primary care based on the language in the Social Security Act, but CMS interpretation is exactly what I've described. 51% have to be primary care as defined by the Social Security Act. Our regulatory guidance comes from 4.2 CFR 491 and all of its subparts. So we can see here the link. If you contact me, I'll send you the presentation material, or I'll put this out on our website. But 4.2 CFR 491, those are the various rural health clinic conditions for participation. They're broken down into these areas. So compliance with federal, state, local law is 4.2 CFR 491.1. The location of the clinic, which stipulates that we're in a non-metropolitan area and that we're in a health professional shortage area as defined by HRSA. Our health professional shortage area has to have been updated within the last 4 years. We'll talk about that in subsequent slides. I'm not going to go through each of these. This is not a rural health clinic compliance presentation. RHC overview, we're covering the basics. These are the areas in which the rural health clinic reg is broken down. So the CFR. So our Social Security or rural health clinic definitions come from the Social Security Act. We have basic rural health clinic requirements that are outlined in 4.2 CFR 405. We have our 491 subpart, as we just mentioned, that give our conditions for participation. CMS interpretation of those conditions are found in the State Operations Manual, Appendix G. It's our appendix for rural health clinics. It's a specific survey guidance relative to the conditions for participation, so it's a really important read if you're a rural health clinic. We have our accreditation organizations, which can establish their own conditions for participation or their own program guidelines, but these have to be approved by CMS and are based on, of course, 4.2 CFR 491. Now they can interpret things and do things operationally a little differently than, for example, the state surveyors may do. But think of Quad ASF and the compliance team like Joint Commission for Rural Health Clinics. Now, they're not nearly as stringent or strict in a lot of ways as Joint Commission, but they serve the same function. They come in, they provide the survey in place of a state Department of Health, and then they're accredited by CMS to do that, so they can have their own program standards, which may be a little different from one another or from what state surveyors may be looking for. Now, if anyone cares, here's our trivia for the day, is Quad ASF stands for the Association for American Association for Accreditation of Ambulatory Surgical Facilities. We call them Quad A. And the compliance team, that's obvious. And there are links on this to either of their organizations, but they're generally now who come in and do the surveys. Most states have now required initial surveys to be done through an accreditation agency and don't really do state surveys anymore. The location requirements, as we mentioned, were we have to be in a non-metro or non-urbanized area as determined by the Census Bureau. So we just got done with another census, so some of our areas may change. We have to be in a health professional shortage area or a medically underserved area. There are 4 different types of shortage designations, and they have to have been updated within the last 4 years. So the practical impact of that is it goes to the end of the 4th calendar year from the last update. So if MUA hasn't been updated since 1978 and there's no other HPSA for an area, we can't get a new rural health clinic. If we have a HPSA that has been updated so today's January 5th, if we have a HPSA that was last updated in 2017, we would have to the end of 2021, we have to the end of the 4th calendar year to establish a new rural health clinic. Now, once we have a rural health clinic established, if an area loses its HPSA or its rural status, the rural health clinic designation is grandfathered. But if you've lost your HPSA or your rural status, you won't be able to move that clinic. So your clinic location becomes static. You will not lose your designation. So in order to establish a new rural health clinic, non-metro area, HPSA or MUA, one of 4 shortage area designation types that have been updated within the last 4 years. These are the 4 shortage area designations. Geographic HPSAs would be a whole county. We have most of our HPSAs in the U.S. are actually population group primary care HPSAs. You'd look on HRSA and you'd see a low income HPSA. That's a population group HPSA. We see medically underserved areas, or MUAs. They count for RHC status, but medically underserved populations do not. Now, medically underserved populations a little different than that population group HPSA, but just know that a MUA counts and MUP does not. And we do have governor's designations that qualify as shortage areas. Not many states anymore have governor's designations, but occasionally we do run into those. So these are the 4 types of shortage areas, and we can't be more than 4 years old to the end of that calendar year. So like I said, if a HPSA was last updated in 2017, we'll have to 12/31/2021 to establish a new rural health clinic. When we lose a HPSA, we don't lose a rural health clinic designation, but we are unable to move that location. Excuse me. So the 2020 encounter cap is 8631. We have a couple things that have changed on this just within the last 2 weeks. First of all, initially the 2021 cap rate was set at $87 and change. I'm not exactly sure. I should update my slide. But we also have the Modernization Act passed. So the Modernization Act on April 2021, the all-inclusive rate cap will go to $100. That rate cap is going to go up $13 annually until in 2029 it reaches $190. It's not a PPS rate, so we're going to file a cost report every year. New rural health clinics will be subject to this new cap. Existing provider-based rural health clinics, we have a problem with the date. Right now, the date of the Modernization Act is any new rural health clinics from 12/19 and later. We need to pursue a legislative fix to hopefully get that changed to 12/2020. But the important ramification is that, first of all, no existing uncapped provider-based rural health clinics will lose their cap or will lose their rate. Existing uncapped provider-based clinics will be allowed to grow their rate by MEI every year. New rural health clinics coming in will be eligible for a $100 rate. So all of our independents now, their rates will be able to move up to and any rural health clinic will be able to move up to $190. Now, there are a lot of ramifications of this. Again, existing provider-based rural health clinics will keep their uncapped rate. New rural health clinics after 12/2019 will be subject to the cap. The cap is going to increase every year up to $190. So it's a sea change for rural health clinics. Most independents and most provider-based will not get up to the $190. There were rates over the $190. There were many rates over $200. There were rates over $300, $400, there were $600 rates out there. As part of the reason we needed this change, because that was not sustainable. So I'm going to record a separate video about the Modernization Act. You'll certainly be hearing more about it. But so this rate cap is now obsolete as of the recording of this video. Let's define the rural health clinic encounter. It's a medically necessary, face-to-face, medical or mental health visit, or a qualified preventive visit. Medically necessary, medical or mental health, qualified preventive health visit, which is face-to-face with between the patient and our physician, nurse practitioner, PA, certified nurse midwife, one of our rural health clinic providers, where we're providing RHC or FQHC services. So for our purposes, most of our guidance for RHC, FQHC come from the same manual. Once we start billing claims, once we start setting rates, we're very different from one another, but we have the same guidance. So we find FQHC and RHC in all of our guidance, and all of the guidance that I use is generally based on Medicare. So I try not to come up with my own language, because we can all interpret things a little differently, so all of this language comes directly from Medicare. Medically necessary mental health visit, qualified preventive visit, face-to-face between the patient and one of our providers at one of our established locations where one or more of our RHC or FQHC services are rendered. That's the RHC encounter. Medically necessary, face-to-face with one of our providers. We have a productivity standard of 4,200 visits for a physician and 2,100 visits for a nurse practitioner or a PA. Now, these are the expected number of visits. So these are prorated for the FTE. So we'll prorate 4,200 for a 0.8 FTE provider. The prorated number of visits becomes the number of expected visits that we'll report on our cost report. So the MAC will substitute the expected number of visits for the denominator and use that for the number of visits if we don't meet that productivity standard. So this is not a compliance issue, it's a cost reporting issue. The MAC will use the expected number of visits in place of the actual visits to calculate the rate. 4,200 is prorated based on the FTE. The most common mistake we see on cost reports are reporting one FTE for one live body. No. The FTEs for cost reporting are based on availability in the rural health clinic to see patients. That's different than our payroll FTE, right? So our cost reporting FTE is based on time available in the RHC, not time that we're paying them for. It doesn't include administrative time. It doesn't include time at the hospital. So time available to see patients. Don't report one FTE per live body. One FTE is 40 hours in the clinic available to see patients. We have almost no full FTEs that we'll report. Most of our FTE providers are 0.8, 0.9. Many are lower than that. Don't overstate your FTEs. You'll cost yourself a lot of money on your rate, especially now that, in effect, independents kind of become uncapped over the next 8 years. Most independents will not be able to meet that cap. So FTE reporting is going to become very important on our cost reports to make sure we don't distort our rate or cost our. So think about it. If we're a 0.8 FTE, our expected number of visits should be about 3,600. If we report 4,200 visits on our denominator, we've diluted our rate by 600 visits. So that's the impact of over-reporting FTEs. So we're going to set, with the Modernization Act, we've kept our all-inclusive rate. A PPS rate would be one where you kind of set it and forget it. But since we have an all-inclusive rate, we have a cost report. Provider-based clinics use the main provider's cost report, and they submit as a worksheet on the main provider's cost report. We have to allocate space and personnel and costs appropriately, and we have to make sure our provider FTEs are measured accurately. We need to do a formal time study, which is 1 week per month for a year, to determine the actual availability in the clinic on the part of our providers. So these FTEs have a major impact on our cost reporting. I think we've talked about that quite a bit now. And of course, we have to reallocate lab expenses because those are non-RHC services. Even though for compliance we have to have lab services, these are non-RHC services for billing purposes. We have to have lab services for compliance. We have to have the 5 basic lab tests for compliance. But those are not RHC services from a billing perspective. We'll talk about that more. All the Medicare world applies to RHCs. We're not special. So all services provided to beneficiaries are expected to be documented in the medical record at the time they were rendered. We don't have any difference. There's no light between us and other Medicare providers. How we bill things is different. We have independent rural health clinics that are generally what we think of as just a private physician office, or hospitals can certainly own clinics and have them independent. Primarily those hospitals that are greater than 50 beds, they may keep their clinics independent, but there are other incentives other than that now changed RHC cap. For example, you have to be provider-based to take advantage of 340B. So there are other issues than just the rural health clinic cap for provider-based clinics, but generally speaking, a hospital can have an independent. We just wouldn't go through the process of formally making it provider-based. So independents always get whatever the current RHC cap is, as long as their cost report justifies that. So they're paid a maximum, I should say, of what the current RHC cap is. Independents have to file individual or consolidated cost reports if we have multiple independents. But we have to file our own cost report, and it's due 5 months after the end of our fiscal year. And if we don't file a cost report, we get our payments cut off and ultimately have to pay it all back. So don't do that. The big difference with provider-based rural health clinics is that they're formally owned and operated by a hospital, nursing facility, or home health agency. It's only provider-based rural health clinics owned by a hospital of fewer than 50 beds that qualify for uncapped reimbursement. And again, the Modernization Act just changed that. So those uncapped, owned by hospitals of fewer than 50 beds the existing ones will not change, but new ones will be subject to the new cap. So again, if your hospital entity is greater than 50 beds, you can still be provider-based, you just be capped. And again, there are other incentives to being provider-based than just the rural health clinic rate. If you're provider-based, you're going to submit your cost report under your parent's cost report, and you're going to bill to the MAC that your parent hospital uses. Many of us are confused on the nature of provider-based rural health clinics. Provider-based rural health clinics are not departments of the hospital. We've got to comply with all provider-based requirements, such as administrative integration, financial integration, operational integration. We can't discriminate against Medicare patients. We have some more stringent rules than off-site locations of the hospital than those on campus. But according to 4.2 CFR 41365, for the purposes of this section, rural health clinics are not a department of the hospital. Now, this has a lot of different ramifications. We have to follow all provisions. We have to be under the hospital's tax ID. We have to be integrated with the hospital. Clinical services have to be integrated. But we're a provider-based rural health clinic. We're not a hospital department. We have different, we're not subject to EMTALA. We can have a separate fee schedule in our rural health clinic than the hospital. We have some waived distance requirements if we're associated with a critical access hospital or a hospital of fewer than 50 beds. But the important thing is we're not departments. So that gives us a lot of flexibility in our rural health clinic that I think a lot of us don't understand that we have. So that's a really big issue to be able to understand. Qualified providers in the RHC or FQHC are physicians, nurse practitioners, physician assistants, certified nurse midwives, and then chiropractors, dentists, optometrists, and podiatrists. So what is missing from this list? It's a trick question. What is missing from this list? There's no specialty on this list, is there? Any MD or DO can see patients in our rural health clinic. Any nurse practitioner can see patients in our rural health clinic, PA, etc. There's no additional enrollment that has to happen for our qualified providers to submit claims under our rural health clinic CCN number. So also, any qualified physician or an NP or PA can come through. So this gives us a lot of flexibility. An encounter can only be billed for the following providers, but any of these types of providers can participate. Now we also have clinical psychologists, LCSWs. Licensed clinical professional counselors are not eligible. Medicare does not enroll them. So our behavioral health specialists or behavioral health providers are LCSW, clinical psychologist, PhD. At the state level, we're going to see that definition is a lot different. But for Medicare, those are our providers. RHC locations are the RHC or FQHC itself, the patient's residence, which includes an assisted living facility. So nursing homes are covered as the patient's place of residence, but so are SNFs. So Medicare Part A covered SNF is a rural health clinic encounter location, as is the scene of an accident. Now, it's in the guidance for some reason. I put it here. I've never seen a claim billed for such. So since it's there, you got to put it there. But clinic, patient's home, SNF, scene of an accident. You don't have to have any special billing to go see a patient in their home and bill a rural health clinic encounter out of it. Of course, it's COVID, so we probably don't want to do that. But you could go to the patient's driveway and maybe not go in their home right now. Nursing home visits are all rural health clinic encounters, as are SNF beds. Now, slightly different definitions at the state level we have to be careful of. And also, we'll never ever have a rural health clinic encounter that is billed out of the outpatient or inpatient hospital. Our RHC providers can see patients at the hospital, inpatient or outpatient, but we're not going to bill those services as encounters. Now, some of our facilities have specific exclusions from RHC FQHC visits, like comprehensive rehab facilities and hospice. Actually, we just had a hospice change with the Modernization Act 2. We're not going to go down that rabbit hole right now. But basically, we're never going to have an inpatient or outpatient service be billed as a rural health clinic encounter. That's even if your option 2 is a critical access hospital that affects outpatient billing. It doesn't change the fact that we'll never have a rural health clinic encounter billed out of the inpatient or outpatient hospital. Again, I've already established that provider-based rural health clinics are not departments, so we've got to do a slide in here. And so now really the $64,000 question, I get this a lot. What goes on our RHC claim? Well, the answer is rural health clinic services are reported on a rural health clinic claim, which is a UB04. Rural health clinic services include physician services, anything incident to physician services. Nurse practitioner services, anything incident to. Clinical psychologist, social worker, anything incident to. You see the trend. Visiting nurse services to the homebound are payable, but only if we're in a home health shortage area. And for right now, during the public health emergency, all HPSAs are home health shortage areas. So for the time being, you can send RNs to homebound patients and have them billed as rural health clinic encounters. I have not seen much visiting nurse service at all be paid in rural health clinic. Incident to services are covered and paid under our RHC encounter. They're bundled with the encounter. They're not separately payable. We can bill services that occur 30 days before or after our encounter. 30 days is not stated in the Medicare guidance, but what is a medically reasonable time frame, which is generally understood to be 30 days. So we have an incident to service that happened on a day different than an encounter. We can bundle it with that encounter anytime 30 days before or after. And then really the only effect is we're going to increase the patient's coinsurance. Medicare is always going to pay 80% of our rate. The patient's always going to pay 20% of the charge. Coinsurance and deductibles are now based on charges, not allowable amounts. When we say to put an item on the cost report, it's really kind of a red herring. The cost report includes all of our expenses for providing medical services as a rural health clinic. So what it's really saying is included in your expenses. There's not a separate line item on the cost report to pay these things separately. So costs included on the cost report, all of our costs are already on the cost report. But it doesn't mean it somehow makes these billable. Incident to services are covered and paid. Under the encounter, we have to report them. They don't change payment. They change the patient's coinsurance. Venipuncture has to be bundled with our encounter. This does not get billed out separately with our lab services. So venipuncture we're going to bundle with our encounter. We have to have a qualifying visit on our claim. We have a list of CPT codes or HCPCS code that represent qualifying visits. So on our claim we have to have, we're going to bill with a revenue code. We're going to bill on a UB04. We have to have one off of our list of our qualifying visits. And our payment and our applicable coinsurance are going to be based on the qualifying visit line, not on a total. Our RHC services are billed on a UB04. The electronic format of the UB04 is called an ANSI 837 institutional claim. If you care, a fee-for-service claim is an ANSI 837 professional. We're billing on institutional claim forms, which is what a UB04 is. It's an institutional claim form. Our type of bill is going to be a 711 for an original claim. All of our services must be reported using the appropriate revenue code. And our qualifying visit that we mentioned in the previous slide gets denoted with a CG modifier. The incident to services we have to bundle on our claim, and they're going to get bundled with a qualifying visit. One of the other fairly confusing aspects of rural health clinic billing is we've already mentioned that we're going to bill on a UB04. We're using institutional claims and cost reports. We are really using Medicare Part A as the administrative structure for our rural health clinic claims. We are a Part B service. So we have Part B coinsurance and deductible amounts, but all of our reimbursement structure is from Part A. So I always like to say that we are a Part A skeleton with a Part B skin as a rural health clinic. So of course we still have the fee-for-service program. And when we talk about Part B in the rural health clinic context, we're usually talking about informally those claims that are going to be billed as a non-rural health clinic service on a 1500 that we're going to continue to be paid under the Medicare physician fee schedule, which we are not as a rural health clinic. We're not paid on the Medicare physician fee schedule as a rural health clinic, even though we're considered a Part B service. So in a rural health clinic context, we're considered Part B by Medicare, but our claims are not paid on the fee schedule. Our non-rural health clinic claims remain payable on the Medicare physician fee schedule, and they're not paid an encounter, and we're going to carve out the corresponding costs for our non-rural health clinic services. We're going to have a section on that here momentarily. So our revenue codes, we can bill any revenue code we want, even though we have a set list that we're really going to pick from. We cannot use one of these revenue codes on the screen because those are rehab and hospice revenue codes, so we would never use those. These are the revenue codes that we're going to use. So we're going to use 521 for our clinic visits, 522 for home, 524 for the SNF, 525 for regular nursing home or custodial care, and on down the line. Now again, I've never seen 527 billed. I don't know a lot of folks that use the visiting nurse aspect of the visiting nurse services. It's generally a mountain frontier thing. 528, visit by provider to other non-RHC site, i.e. that scene of the accident thing. I've never seen either of those used, but this is how we would do that. Our generic hospital meds, we're going to bill under 250. Our injections are going to be billed under 636, including administration. Venipuncture, we're going to use for 300. Telehealth, originating site only, is 0780. Behavioral health is 0900. So those are the revenue codes that we're going to use. We're going to use our regular customary fees. We're not going to change our fee schedule because we're a health clinic. So we keep everybody's fees the same. But our payments come back as 80% of our RHC rate plus coinsurance, which is based on the charge. So we're going to 80% of our rate plus coinsurance based on the charge, and that's not going to change other than if there's a deductible amount. So visiting specialists, when they come into RHC, like I said, they're paid as any other MD, DO, and PPA would be in our RHC, as long as 51% of our total provider hours are primary care. Specialists can pretty easily be integrated into the RHC. Of course, when I said we don't have Medicare enrollment, especially when we just come in and bill under our CCM number, our CCN number, a rural health clinic provider number with their MPI. But of course, for commercial and Medicaid, Medicaid MCO, there would be additional enrollment. This is what a claim would look like. We have an established patient for 99213 at $100. We've got that CG modifier, which represents our qualifying visit line. Pretty straightforward claim here, right? 521 from the office, got a total charge line. Remember, we don't adjudicate claims based on the total charge line. We adjudicate claims based on qualifying visit line. So we have to bundle our Incident 2 services up to the qualifying visit line. So in this example, we show how that's done. We have an injection and administration for $20 and $30 respectively. We bundle those up. It means we add them to our qualifying visit line. So now we have revenue reported twice on our claim if we report the claim this way. It's perfectly acceptable. The claim will adjudicate for $150 in charges. The patient coinsurance will be applied based on $150, even though that $200 total charge line will show up on the claim. It's irrelevant. It's just, we don't adjudicate based on the total charge line, we adjudicate based on the qualifying visit line. So if we use the straight billing method, we're going to have an extra $50 in our revenue that will adjudicate out when the claim pays. The other way we like to see these done is what I call the alternate method. Basically, we report that service detail for a penny, and the claim looks like this. We don't have the extra revenue to account for. So it becomes, we're billers. I don't like to answer for or have fake revenue in our figures, even though there's nothing wrong with it. Most of us have settled on this method to bill in. Of course, how we do that depends on our practice management systems and what our software requires us to do to get the bill out. Preventive services are RHC encounters, so we get paid a professional component as long as we haven't met the frequency limit, so our same frequency limits apply. Of course, for preventive visits, just like in a regular office setting, paid on the physician fee schedule, which we're not. We will not have coinsurance or deductible for our preventive visits. That's part of the reason that we can't adjudicate the claim based on that 001 line item, because we can't have coinsurance in our applied to our preventive visits. So preventive services include, of course, a welcome to Medicare, annual wellness, subsequent annual wellness visits, the rest of the Medicare preventive screenings. It's important to note that diabetic self-management training and medical nutrition therapy by a registered dietitian is not an RHC service. They are FQHC services. They're not RHC services. So all the Medicare screenings are allowable encounters except for that diabetic self-management training. Flu and pneumo, we are paid for those, but those are paid on our cost report, so we don't submit claims for those. And we are also eligible for care management. This year we got principal care management and virtual communication services. These are all considered preventive services. And you see on here the G0511, G0512, we have some RHC specific codes that we're going to use to report these. We have the ability to bill and receive a separate payment for an encounter in addition to our sick visit when they're performed on the same day. So basically we can get 2 encounters on the same day for a sick visit and a welcome to Medicare visit, or IPPE. So the IPPE is eligible for same-day billing. None of the rest of the preventive visits are. The rest of the preventive visits are what are known as standalone encounters. So a standalone encounter is one that if it's provided by itself, it's paid as an encounter. If it's provided with another standalone service or another encounter, we only get 1 encounter. We don't have any coinsurance or deductible on these. If it's billed by itself, it's paid an encounter. If it's billed at the same time with something else, we only get 1 visit. We're going to look at a couple examples of those. So, non-RHC services. The services outside of those in our RHC benefit that we're able to bill for and get fee schedule payment as long as we're authorized to bill these services. So not only can we bill these services separately, these services must be billed separately and not by the RHC or FQHC. And we're going to bill them to the appropriate MAC for whom the rules apply. And for anything that we're going to bill in this manner, that we must bill in this manner, we're going to carve the costs out of our cost report. So we have a certain subset of services for which we must bill fee for service. We cannot include them in our RHC claim, and we cannot include them in the line items that the patient would have coinsurance on. So we have to split these out. And on lab services, we have 5 lab tests that we're required to be able to provide, but that doesn't mean we bill them rural health. So our technical components and all of our lab are non-rural health clinic services that we must bill outside of the RHC encounter. We're going to build a professional component of any of these diagnostic services. The professional component gets billed with the encounter. The technical component and our lab services get carved out and billed fee for service. So all day, every day, we can carve out what are statutorily defined non-RHC services and bill them in addition to our RHC FQHC claim. These include anything that is Medicare excluded, include our technical components, lab services, so all EKG, ultrasound, x-ray, all day, every day, technical components get billed separately and not part of our encounter, and that includes those lab. Distant site services, look at that, distant site services are non-RHC, so we carve those out and get a fee-for-service payment for some of those. Group services are not recognized by Medicare. Ambulance, prosthetic, body braces, services at certain other facilities, so our hospital, inpatient, outpatient is going to be included on those, and hospice. So we're going to break these down a little bit. So our non-rural health clinic services include these diagnostic tests, lab services except venipuncture, and professional services in the hospital. We're not going to bill those to as part of our rural health clinic encounter. They must be billed non-RHC. Independents and cause and provider-based clinics are going to bill these differently from one another. Okay? So a non-rural health clinic service is going to get billed for fee for service, but cause are going to get cost-based reimbursement on their non-RHC services. Independents and RHCs owned by a PPS hospital are going to get paid on the fee schedule. So our physician services at the hospital, I've meant 1,000 times to get that Medicare carrier out of this presentation. Physician services at the hospital are fee for service. They're not rural health. They're not in our cost report. Remember when we said we're never going to bill an inpatient or outpatient service as a rural health clinic encounter? Even if we're option 2, critical access hospital, that only affects the outpatient services at the hospital, not our rural health clinic bill. So our rural health clinic providers go see patients at the hospital. It's a fee for service claim. Our RHC providers go provide outpatient services in a call, and we're option 2. It's a hospital claim. It's cost-based. It's still not a rural health clinic claim. So hospital services are always going to be non-rural health clinic services. So here's just a little bit of a key of where we send our non-rural health. So our independent non-rural health clinic services get billed under a Medicare Part B group number. This is the biggest difference with our provider-based clinics. Our provider-based clinics, the non-rural health clinic services, get billed under the hospital CCN number, not a Medicare group. A hospital CCN number, even for the services that are performed at the RHC, they're going to get billed under the hospital provider number. So we've carved those costs out in order to bill these separately, and our cost reports all show reclassifications for lab, hospital, diagnostic testing, etc. Let's talk about telehealth services. Prior to the public health emergency, RHCs could not function as distant sites. We could only be an originating site. So a distant site is where the provider is, and by statute, the patient's home could not be the originating site, which is where the patient is. So prior to the public health emergency, we were only able to bill as originating sites out of the RHC or FQHC. If we have, includes teleservice provided by RHC practitioner and employed or under contract, So either way, our RHC providers, we could not bill distant site. Originating site gets reported as that 780 revenue code, and Q3014 is the HCPCS code, and we could bill that on a claim with another service. The remote, so basically, as the originating site, we're only getting paid for setting the patient in front of a camera so the remote physician could bill the E&M code. The remote physician gets a fee-for-service claim. The RHC only gets that originating site. Now that's all pre-COVID, right? So during the COVID emergency, we have our G2025. And our G2025, we're going to be paid for at $92.03. G2025 represents the aggregate for all Medicare approved telehealth services. So it's a weighted payment based on all 240 now CMS approved telehealth services. And we had kind of a phased in implementation of how we're able to bill for that G2025. So during the public health emergency, our distant site providers can be any health practitioner that's adequately licensed in the state practicing in their scope of practice. So practitioners during the public health emergency can be at their home, practitioners can be at the clinic, practitioners can be anywhere else and service patients from wherever the patient is during the public health emergency. So any service that is on that Medicare list of approved services can be provided and billed using G2025. Telephone only visits, which I expect will go away after the public health emergency ends. The question is, will our ability to be the distant site, so the patient can be at their home and we're seeing the patient via telecommunications, and will we preserve that after the PHE? We don't know. What I can guarantee is if we preserve that after the PHE, I think these telephone only visits will go away. Right now we can get this G2025 for a telephone only visit. I think that when the emergency ends, we'll only be able to bill G0071 virtual communication service for a telephone visit. Right now, during the public health emergency, telephone only visits count for G2025. We can bill that for G2025, telephone only visits. Stay tuned for after the public health emergency what happens to those. So we're able to bill this G2025 going all the way back to January 27th, but our distant site ability only goes back to March 6th. We don't want to go down all that rabbit hole. It was a really painful several months waiting for that guidance to come out. So that this is what our telehealth visit looks like. After July 1, we're not putting a CG modifier on our G2025. These claims are going to pay at $92.03, and the patient's going to be responsible for 20% of $92.03. So don't charge up an increased rate on these. Medicare is going to pay. They're going to kind of act like an allowable on this, where it doesn't matter what you charge. They're going to base the payment on 80% of 9203, patient coinsurance 20% of 9203, regardless of what you charge. So this is what our distant site telehealth services look like during the public health emergency. Remember I said it's a weighted average, so after December 31st, well, it's after December 31st, we're about to get a new weighted average for that G2025. And any provider during the public health emergency can provide distant site telehealth services. That includes an RN providing 99211 services via the telephone. That's only via the telehealth and only during the public health emergency. And now it's more than just an email. It's cooked into the to the ML Matters article for this. But any licensed provider appropriately licensed in their state can see patients and bill a G2025 for $92.03, including our RN. Medicare Advantage plans basically come in two flavors. Those that are going to pay your encounter and those that aren't. Those that are going to pay your encounter, you have to perpetually send them your rate and submit the claim on a UB04 according to Medicare billing rules. Non-RHC services generally submit those on a 1500. If they're not paying you your rate, you're just going to submit on a 1500 to them. The problem is if you're being paid your rate by your Medicare Advantage plans, what they're going to do with your flu and pneumo shots, because we don't have any way to report those on a cost report to them. So Medicare Advantage plans, many will pay, most of the time the Blues will not. So most of the plans pay the encounter rates. It's always a matter of how you and whether or not you can get them to pay that. So let's talk about care coordination services real quick. There were a number of changes that happened to these after they were first introduced, so that the initial iteration of care management services weren't really doable because we couldn't do them under general supervision. Now they've loosened up so that we can, as rural health clinics, provide 20 minutes of care, clinical care, to any patient with 2 or more chronic conditions. We're going to bill the G0511. We're not going to bill any of the fee-for-service codes on these. So all of our billing will be a couple of these specialty codes, like the G2025. For the general care management service, we get a G0511, and that is set at, again, it's this weighted average of the fee-for-service codes for those. And the 2020 payment was $66.77. I have the 2021 payment, but obviously not on the slide. That does get updated annually, and co-insurance applies. We've got, this year now, we've got primary care management. So primary care management is if the patient has 1 chronic condition. Option A is if the patient has 2 chronic conditions, 2 or more chronic conditions that are expected to last 12 or more months. I think we know that drill by now. But look, we also get this option B. So any behavioral health or psychiatric condition treated by our providers, including substance abuse, constitutes a G0511. So we have 2 options for that. And we have this elevated psychiatric coordination of care, which I think is really interesting. It's a higher threshold, but it's a G0512 and it's a $145 payment. We have to have an initiating visit, and of course, for any of the care management, we have to have an initiating visit. That initiating visit may have occurred within the past year for both of these billing options. For the G0512, the first month we would have 70 minutes of care in the first month, and the subsequent months we have 60 minutes of care. And we have our RHC practitioners. We also have this behavioral healthcare team. So G0512 is an interesting care management service not to disregard. Now, for quality payments in the RHC, generally MIPS is not applied to us. We have no way to participate unless we bill more than 90,000, that's 90,000 in allowables over the course of the year to Medicare Part B. Most of us are never going to have that much volume. Even our docs that are seeing patients in the hospitals rarely have that much Part B. And at that point, you can opt in to MIPS. The problem is Medicare doesn't have a great crosswalk, so that even though we're not eligible for the upside of MIPS, most of us don't meet the low threshold requirements. We still get hung up in the negative payment threshold. So a lot of us participate in ACOs, maybe through the hospital. Patient-centered medical home offers a route through to receive some quality payments. Commercial payers are starting to recognize quality payments, but for right now, there's no way for rural health clinics to participate in MIPS if we don't meet that low volume threshold. So we're subject to the negative and positive, we're subject to the negative adjustment because Medicare doesn't have any way to know that either we're a rural health clinic or we don't have enough volume. So even though we can't participate in the positive adjustment, we automatically get the negative adjustment applied to us. If you don't have any fee-for-service billing, it doesn't matter anyway. But we do get stuck in this trap. So I've got a lot of different resources on here. Most of the language I use is directly out of one of the Medicare manuals. I encourage you to look at these resources. There's a lot of good information in them, and I always have that benefit policy manual open on my desktop. Always, always. So otherwise, this is me. I hope that you've learned something and that this has been beneficial. And please don't hesitate to contact me with any questions. So thank you very much.